Cancer, presented by Dr. Anuradha Maji, third year junior resident at SSKM IPGMR, and Dr. Deependra Sarkar is here to moderate the session. And Anuradha, you can start.
Okay,
Stop
sir.
at the end of history. Okay.
Okay, sir. Sir, today my case presentation is of an early breast carcinoma. Patient parameters. Patient is Mrs. A, 56 years of age, female. She is hailing from Noihati, and she presented to us on 4th of November 2022. Her chief complaint was a swelling in the right breast for the last 3 months. She was apparently well for the past 3 months when she noticed a swelling in the lower outer part of the right breast, which was around 1 centimeter in diameter. The swelling has been gradually increasing in size for the past 3 months to the present size of around 3 centimeter in diameter. There was no history of any pain or any nipple discharge. There's no history of ulceration of the skin over the lump. There were no complaint of swelling in the opposite breast or armpits. There were no complaints of any chest pain, cough, breathlessness, abdominal pain, new onset headaches, backache, or jaundice. Past history: she is known hypertensive for the past 4 years. She took tablet amlodipine 5 milligram once daily, and there's no history of any other comorbidities. There is no history of any other any allergies. There's history of oral tobacco paste use for the past 10 years. There's no history of previous breast diseases or biopsies. Personal history: her appetite was preserved. She took mixed diet. Sleep was normal. Bowel and bladder habits were within normal limits. She attained menarche at around 13 years of age. Her menses were regular, normal volume, 28 days cycle. She was para 2, live 2. First childbirth occurred at 28 years of age. It was a full term pregnancy, and she breastfed first child for 2.5 years. Her second childbirth occurred at 33 years of age. It was a full term pregnancy, and she breastfed her second child for 2 years. There's no history suggested of any hereditary breast diseases in the family. There's no history suggestive of breast, ovarian, colon, stomach malignancy in the first or second degree relatives in the family. So this is my history.
Okay.
So first, Anuradha, from the history, now, what is your impression? I mean, just looking at taking the history, what is your impression?
Impression is a right-sided breast lump,
Okay.
which has been presenting for the past 3 months and progressively increasing in size, painless in nature, and associated with no other complaints.
Okay, but you have in history used the term gradually. Okay, so
Yes.
if you look back, you told that she detected a lump 1 centimeter in size and now it's 3 cross 3 centimeter with a gradual progress. I would object to using the term gradually when you are trying to emphasize the breast carcinoma. Clear? So
Okay, sir.
progressive is a better term, but if you tell gradually, that would go more in favor of a benign lesion. That is one point. The second point is at your level,
More than double in 3 months' time. The lump has become more than double in 3 months' time. So
Yes,
it is likely that, so 3 months' time, the lump was 1 to 3 centimeter. More than double in 3 months indicate it's a relatively rapid progress.
Yes, sir.
Second, when you are presenting at MS level, you need not go on telling no history of headache, no history of jaundice. You can tell there is no history which is suggestive of any metastatic symptoms. Okay, so
Yes, sir.
because you cannot go on telling there are so many symptoms, you might miss one of them. Clear? Now, I would like to ask you few questions from the history. What are the endocrine factors which are predisposing factor for causation of breast cancer?
Endocrine factors would be high estrogen exposure in the lifespan of the patient.
No, you just now again Anuradha, don't try to initiate like high estrogen exposure. You tell that 1, 2, 3, 4, 5, 6. These are the factors which promote breast cancer. Start.
Yes, sir. Sir, early menarche, late menopause.
What is early?
Early menarche is before 11 years of age.
Okay.
Menarche before 11 years of age. And late menopause is menopause after 60 years of age.
60.
Yes, sir.
No, 60 is too late.
Have you ever heard of any menopause having at 61 years of age?
What is the usual age for menopause? Usual age?
45 to
Yes.
50 years of age.
Yes.
So any menopause after the age of 51 years you can consider, but 60 is not an age of menopause, isn't it?
Okay, sir.
Okay. Then
nulliparity,
mhm.
repeated abortions and absence of any full-term pregnancy, and late conceiving in a female patient.
What is late? How late is late?
After 35.
There are mixed evidences. Some people tell fast pregnancy after the age of 30 years. There are other evidences that it's after 35 years. But by and large, fast pregnancy more than 30 years of age increases the risk. Next.
Next is, sir, the breastfeeding, not
Yeah.
completing or not initiating breastfeeding, or not completing complete breastfeeding till 2.5 years of age.
Breastfeeding theory is not tenable now.
Okay.
Breastfeeding theory was earlier there, but at present, breastfeeding theory is not tenable for risk for breast cancer.
Sir, actually, recently, once again, WHO is coming up with an atlas, which I will give it to you on 4th February. The new WHO atlas is once again revisiting the theory of breastfeeding, sir. They are telling non-lactation once again is considered as a risk factor. They were recently in IPGMR and they were making this presentation, and the atlas will be launched, which is a very good atlas for everything is included of breast cancer. That atlas is stating once again that breast lactation has got a link.
Okay.
Next, Anuradha.
And sir, in presence in any known case of PCOS, polycystic ovarian syndrome, or
PCOS. No. You tell me how PCOS linked to malignancy. Where did you find this evidence?
high
PCOS is
estrogen
not
exposure.
hyperestrogenic state. PCOS is not hyperestrogenic state. It's the reverse.
Yes, sir.
PCOS is not a risk factor for breast cancer.
Okay, sir. And sir, in earlier years where high dose oral contraceptive pills were used, that used to be a risk factor for breast carcinoma, but not anymore.
No, I don't get your point. Earlier years, high dose oral contraceptive pills means?
High estrogen, more than 30 milligram of
So
estrogen.
yes, the answer should be precise. High estrogen containing pills are risk factors. Okay.
Yes.
So, but you must remember that in a patient who you are presenting a history who is at 65 years of age, the history of oral contraceptive pills is important because she has taken the pills 25 years back.
Yes.
Yeah. And at 25 years back, the pills used to be rich in estrogen. The present day pills in the last 1 decade had shifted to estrogen predominant pills, and therefore the incidence is lower. Clear?
Yes, sir.
Next.
Mm,
HRT?
uh, yes, sir. Hormone replacement therapy is a risk factor for
But
It's very important risk
osteoporosis.
factors. You should come up with these risk factors very fluently. Okay. What
Sir.
are the hereditary risk factors for breast cancer?
BRCA 1 and 2, HNPCC.
No, I'm not
Uh,
asking about the genes. I'm asking you what cancers in the family would predispose a lady to breast cancer.
Ovarian carcinoma,
Hmm?
presence of breast carcinoma in the first and second degree relatives,
Mm-hmm.
and apart from that, stomach carcinoma, colon carcinoma, prostate carcinoma.
and pancreas.
Uh, yes, sir.
Pancreas also. Pancreas.
Pancreas also.
Male breast cancer, father having breast cancer, does it increases the risk?
No, sir.
Yes, it does increase the risk, and it's
BRCA2 related gene.
true.
Okay, sir.
Okay.
Okay, sir.
Anuradha, you said there is no history of hereditary breast diseases. What did I to mean? Apart from malignancy, is there any other hereditary breast disease?
No, sir. I meant malignancies only, sir.
Okay.
So next is what do you understand by hereditary breast cancer? What do you understand by familial breast cancer? And what do you understand by sporadic breast cancer?
Sporadic breast cancer are the breast cancers which are not having a family history and are uh, doesn't follow any hereditary pattern. And genetic hereditary breast cancers are those
Then
who
familial. Define familial. Sporadic is
familial
index case. No other malignancy, any member of the 2 to 3 generations. Familial?
familial there are in 2 to 3 generations there are cases of breast carcinoma, but there are no specific genetic cause that has
Not only
been found.
breast. Breast or
Ovarian.
Breast or other related malignancy. You have already enumerated.
Yes, sir.
But what is the difference with the hereditary breast cancer here?
Hereditary breast carcinoma have a specific genes that are responsible for the breast carcinoma in the family.
So what is the pattern?
Usually
If you go to the breast cancer characteristics, what is the characteristic of a hereditary breast cancer patient? It occurs at this occurs at earlier age.
yes, sir. It occurs at earlier age.
And it is transferred autosomal dominant inheritance. And you can find that almost all members are affected with some form of cancer. Okay, familial means there is some history of malignancy which is scattered, not following any definite genetic inheritance. But in hereditary, it's the autosomal dominant inheritance. You must differentiate 3 groups. Which one is commonest?
The sporadic breast carcinoma is the commonest.
Yes.
So if I use a term, it is in hereditary breast cancer, there is a defined pattern. Okay, like one breast cancer, bilateral breast cancer less than 40 years of age, or one breast cancer, one ovarian cancer, one ovarian, two breast cancer, like this. Whereas in familial breast cancer, it is called an unnatural clustering of cases without a defined pattern.
Yeah.
Unnatural clustering, like somebody has got a medulloblastoma, that also is an unnatural pattern. In the family, one case of say pancreatic cancer, one case of brain cancer, and then ovary. That is an unnatural clustering, but no defined pattern is there. So that is called familial breast cancer. Clear?
Okay, sir.
Okay, proceed next. Maybe we will proceed to the next physical
Sir,
examination.
so coming to physical examination, the patient was alert, conscious, cooperative, moderately built and nourished. Her BMI was 30 kg per meter square. Her vitals were stable. Pulse was 94 per minute. Blood pressure was 130 by 80 millimeters of mercury in sitting position. Respiratory rate was 16 per minute. She was afebrile. There was no pallor, icterus, clubbing, lymphadenopathy, or pedal edema. On local examination, the
Just
patient
a minute.
was.
Anuradha, I would like to ask two questions. Number one, in general survey, did you find anything specific that would predispose the lady to the causation of breast cancer?
Obesity can be a predisposition,
And
and
do you think that this patient was obese?
she was obese. 30. She was an obese patient.
So BMI 30 is obese, okay? And
Yes, sir.
can you tell me what is the link between causation of breast cancer and exercise?
Exercise reduces the controls the blood glucose levels. It reduces the predisposition to diabetes mellitus. So exercise has a protective role against breast carcinoma.
I don't understand. You told it reduces
Relative
diabetes.
risk.
You told that it reduces diabetes, but how will diabetes reduce breast cancer?
uh, hy- Hyperinsulinemic state in type 1 in type 2 diabetes mellitus, they have increased predisposition to, has been shown to have increased predisposition to breast carcinoma.
I didn't get you, my dear. You are once again stating, if I get you correctly, that type 2 diabetes mellitus increases risk of breast cancer. Are you stating that?
Yes, sir.
Are you sure about this statement that diabetes predisposes to breast cancer?
No.
No, I can't take this because there is no evidence as far as this is concerned that diabetes predisposes to breast cancer. What has been shown, and it's a robust type 1 evidence, that 150 minutes of exercise a week reduces breast cancer by 33%. That is a robust type 1 evidence that has been generated. Yes, I also agree that causation of breast cancer is linked to a particular insulin-like growth factor 1, but that is not linked with diabetes. Clear?
Okay, sir.
Okay. Would you like to specifically mention the performance status in your physical examination?
Sir, ECOG 0, sir, in this patient.
So ECOG 0 and Karnowski was?
100.
Okay.
100. 100 is no disease.
Oh, no.
100 is asymptomatic patient.
Oh, okay, sir. 90, sir.
90. Patient has mild symptoms and signs of the disease. Should be 90 at least.
Okay, sir.
Okay. Now proceed to local examination.
On local examination, the patient has been examined in sitting upright with arms by the side, sitting with arms raised over the head, and on leaning forward, and also in semi-recumbent positions. On inspection, bilateral breast was symmetrical, bilateral nipples in normal position. There was no visible lump, no skin changes or nipple retraction or any discharge. On leaning forward, bilateral breast fell equally, and on raising arms above the head, bilateral inframammary folds and axilla appear to be free of any visible lumps. On palpation, there were
On
no
inspection, just hold on. Now, can you tell me what is the purpose of asking the patient when you inspect, when the arms are by the side, what are the things you examine in this position?
we check for the symmetry of bilateral breast,
Okay.
We check for nipple retraction, presence of any nipple retraction,
Mhm,
any visible skin changes, any nipple areola changes,
mhm,
any presence of any engorged veins,
mhm.
or of any chest deformity, associated chest deformity, and also arms if there's a swelling.
Okay. Now, how can you assess ptosis?
In a patient, we have to ask the patient to look forward, and if the
Any ptosis of the breast, not eye.
Yes, ptosis of
sir,
the
If
breast.
the breast is pendulous, can you inspect the inferior quadrant of the breast in sitting posture, arms by the side?
no, sir.
Then you have to specify that. If you have to specify what Dr. Sarkar is asking, if there is a ptotic breast, you cannot see the inferior quadrants in this posture.
Okay, sir.
So what, can you tell me what in breast would be like ptosis? What is ptosis? Not
Mm,
the general layman's term. How do you objectively assess ptosis?
sir, I'm not sure.
Okay. Normally, the nipple areola complex should be at the level of the inframammary crease or above it. If
Okay.
the nipple areola complex is below the level of the inframammary crease, then it is stamped as ptosis. Depending on the extent, more than one space, it is one, more than two space, two, three is three, four is four. Okay, so grade 1, 2, 3, 4 ptosis. So normally the neck is at the level or above the level of the inframammary crease. Clear?
Yes, sir.
How do you assess the breast size of a lady?
Mm,
Though this would come in palpation, but I am asking you because in palpation we will go straight to other things. But still, how would you assess the breast size of a lady? In modern day, when you are doing an oncoplasty, it is important to understand the breast size.
Yeah.
What is a cup size?
mm,
You know or you don't know?
sir, I don't know the definitions.
Okay. Normally, when you take a measurement at the level of the neck, that's a circumferential measurement of the chest wall at the level of the neck. You take a second measurement of the chest wall at the level of the inframammary crease, and you divide the two. Suppose you take a measurement at the level of the neck, and you find that the circumferential diameter of the chest wall is 36, and then you divide that 36 by the inframammary crease, which is 34. So there is a gap of 2 inches.
Yes, sir.
So 1 inch, more than 1 inch is cup B, then 2 inch is cup C, 3 inch is cup D, then 4 inches is 2D, like that. So depending on the difference of the circumferential diameter at the level of the neck and that of the inframammary crease, by every inch the cup size changes. And the circumferential diameter at the neck level is what is considered as the breast size. Clear?
Diptendra sir.
Yes, yes,
Hello.
madam.
Manju Banerjee. It's not division, it is minus.
Yeah,
The measurement at
minus.
the
Sorry,
neck
sorry.
level minus.
Minus, subtractive.
Okay.
Sorry.
Yeah,
I mean,
and the smaller distance is A size, and the bigger distances go to ABCD,
exactly.
ABCD, double D. Okay.
No, so I told divide. No, sorry. I meant
That was okay.
subtraction. Clear?
Thank you.
Yes, sir.
So in modern day, you have to tell that the breast is 36B or 36D. Then you actually know the breast volume, and the oncoplasty can be planned according to that. Clear?
Yes, sir.
Okay. Then what is the purpose of asking the patient to elevate the hands above the head?
There are two on elevation of the hand, of the arms above the head, we can visualize the presence of any nipple retraction, which may not be evident on just arms by the side. And we can also might be able to see the inframammary folds, and might be see the any obvious axillary fullness.
Anything in the lump overlying the skin?
Or
Any
yes,
change can
sir.
come up?
If any, if the lump, especially in the lower outer quadrant or lower inner quadrant lump, if
Any site, if there is skin tethering, you may
yes,
appear
sir.
some dimpling or lifting the
Yes,
hand above the head,
yes, sir.
So,
which may not be obvious on static posture in the hands on the side.
so basically, Anuradha, you are by making this movement, making an occult involvement manifest. There's an occult involvement, it become more manifest. Clear?
Yes, sir.
What is the purpose of asking the patient to stoop forward?
To see whether bilateral breast fall equally. If there is a presence of a lump which has involved the Cooper's ligament, then the diseased breast will fall less forward than the
No.
normal
Cooper's
breast.
ligament, disease breast will not fall less. Something else.
Mm.
If there is Cooper's involvement, the breast will fall forward equally. If it is not falling forward, what is the problem? Not Cooper's, something else.
Uh,
To
nipple
what?
retra-
Yes, you tell what to what it is stuck. I mean, that's
Yes.
common sense.
Yes, sir. Nipple retraction will be more obvious on falling
Nipple
No.
forward.
To what it is stuck? It can be stuck to chest wall or to
Yes, sir. It
pectoralis.
is. Yes, sir.
So will that allow free hanging of the breast if the lady stoops forward?
No.
So that is what is your answer. What is the purpose of asking the patient to put the arms on the waist?
On putting the arms on the waist, we are contracting the pectoralis major muscles.
No,
So
you are
patient
not.
has to press.
You
Patient
ask
has to
the
press.
patient to contract.
Uh,
What do you see in that?
So the voice cracked, so I couldn't hear the question.
And then if you press on the waist, the muscle gets contracted. So
Yes,
what subtle finding may become more obvious?
While on palpation,
Then not palpation. You are doing
on
inspection.
inspection. Okay.
Patient is contracted. Some
Yes, sir.
subtle finding may become more obvious on this maneuver.
What structure becomes prominent when the patient contracts the arms on the waist?
Pectoralis major.
So what will become prominent?
Any lump which is fixed to the
Yes.
pectoralis.
That is one. Nipple detection may become more obvious.
Yes, sir.
Skin dimpling may become more obvious. Okay.
Yes, sir.
What is the purpose of inspecting in the semi-recumbent position?
In case of voluminous and pendulous breast, where in semi-recumbent position, it is easier to palpate.
Even
Yes.
inspect.
Inspect.
On palpation, sir.
Even inspection, you cannot see the inferior quadrant in a pendulous breast. So you make the patient recumbent. The whole breast you can see now in profile.
Yes, sir.
So you must understand that the standard international position is the semi-recumbent position with the arms elevated above the head. Now in
Yes.
this standard position, you just imagine it's a semi-recumbent couch of 45 degrees. The lady lies down and puts the arms over the head. So what it does, it allows you the inspection of all the quadrants and the zones of the breast, including the armpit, as well as the neck, as well as the arms. Okay. So no other position would give you this advantage. So internationally, that is just considered as the standard position. But in our setup, we do not have couches. So we would go ahead with the other positions. Clear?
Yes, sir.
Go to palpation.
On Starting with palpation of the normal breast, left breast, there was no abnormality noted on palpation. In the right breast, there was no local rise of temperature or tenderness. There was a 3 into 3.5 centimeter lump palpable in the lower outer quadrant at 8 o'clock position, whose the medial border was around 10 centimeter away from the nipple areolar complex. The skin of the swelling was normal and pinchable, and the lump had irregular, well-defined margin, nodular surface, hard consistency, and it was moving along with the breast tissue. It was not fixed to the skin or chest wall, and there were no palpable axillary lymph nodes or supraclavicular lymph nodes bilaterally.
I would like to ask you one question. How would you assess the fixity of the lump with the breast tissue?
So we have to support the breast by on our palmar surface of our fingers,
Yes.
and then we have to move the lump. So if the lump is moving uh, along with if the movement of the lump causes movement of the breast tissue, then it is fixed with the along with the breast tissue.
Okay. How would you what do you understand by skin involvement?
Skin involvement can be in the form of ulceration, in the form of satellite nodules or podorange.
Okay. How would you differentiate between a tethering? Would you consider tethering as skin involvement?
No.
How would you differentiate between tethering and that of involvement?
Tethering is usually due to involvement of the Cooper's ligament, due to which there is some shortening of the Cooper's ligament at that, which reflects as a dimpling over the skin surface.
But
the cutaneous involvement is with malignant cells is absent.
Clinically, how would you differentiate?
Can you pinch the skin if there is a
Yes.
dimpling?
Dimpling,
So
with dimpling,
is
the
pinchable.
skin is pinchable.
Skin is pinchable. Second is you try to make a pendulum like movement of the breast. If you are able to move at least few centimeters without movement of the overlying skin, that is tethering. Actually, the term is at the extremes of the pendulum like movement, the skin is tucked in. Whereas involvement, you cannot move the lump even a millimeter without movement of the overlying skin. Clear?
Yes, sir.
Okay. So then you told that the axillary lymph nodes are not palpable. What are the nodes you have palpated?
Sir, I could palpate the central group lymph node and tried to palpate the apical group, anterior group, posterior group, and the lateral group.
Okay. So, uh, how would you palpate the deltopectoral group of nodes or intraclavicular group of nodes?
Sir, we have to support the arm. So if we are palpating the right side of the axilla, then we have to use our right hand for palpation and support the patient's right arm over our left shoulder. Ask the patient to relax. We have to reach till the apex of the axilla, and in a sweeping down motion, we have to palpate from
No,
top to bottom and feel for any.
That is not deltopectoral nodes. Deltopectoral nodes are infraclavicular nodes. So it is always done by bimanual or by digital palpation. It is found in the deltopectoral group. Your right hand for the right breast would be placed in the deltopectoral group in front, and the left arm the left fingers goes behind the pectoralis major into the groove, and you palpate in between the two. That is considered as the infraclavicular group of nodes. Okay. And then you have also done a systemic survey and you didn't find anything, isn't it?
Yes, sir.
So what is your diagnosis?
Sir, I would like to give a provisional diagnosis of early breast carcinoma. Clinically, it is T2, N0, M0.
It's not enough. You have to write something else. Premenopausal lady. Okay, if you give a diagnosis at PG level, it should have some more connotation.
Actually,
Quick,
Anuradha, in a PG level, a perfect diagnosis would be, as Sir has pointed out, a premenopausal lady with a breast cancer, right-sided. You can tell the TNM is T2, N0, M0, the stage grouping being stage 2A. Okay,
Yes, sir.
so that
Yes.
gives you a complete diagnosis. Or else the next question will be, what is the TNM? What is the stage? Correlate between the two. You are wasting the examiner and your time on simple questions. Clear?
Okay, sir.
So if you tell it's a breast cancer, what are the possible differentials? State two differentials.
Sir, phylloids tumor.
3.5 centimeter. Why do you start with the phylloids first? Why not a fibroadenoma?
Yes, sir.
Phylloids are usually lobulated large tumors.
Yes, sir.
It can be,
Yes, sir.
what is the age of the patient?
35.
35.
No, sir, 65 years old.
Oh, 65. Okay.
65. So if
Then
it
it's
is,
unlikely to have fibroadenoma. No.
so if it is 65, what are the possible differentials?
Yeah.
Sir, breast carcinoma, and apart from that, phyllodes tumor.
Phyllodes again is very, very uncommon in 65 years of age. Phyllodes is usually in the early middle age.
Yes.
Yes, sir.
A lump mimicking malignancy can be found in elderly patients, which can mimic malignancy with skin retraction, traumatic fat necrosis.
Okay, sir.
Okay. So Anuradha, as Sir has told, one would be traumatic fat necrosis with or without history of trauma. Anything else that comes to your mind? The commonest, another very common entity is when you don't have a overlying skin involvement, anything, is a breast cyst. A macrocyst of the breast can present with a lump in the breast. You do an ultrasound and find it to be a unilocular cystic lesion. In the peri and the postmenopausal age group, it is a common finding to find a big lump filled with fluid. So that's a macrocyst of the breast. If the lady had presented with overlying skin involvement, etc., what would be your next differential? If there is
Breast
skin
abscess.
involvement, yes, tell.
Breast abscess.
Or breast or chronic breast abscess. Why would there be a chronic breast abscess?
Granulomatous breast disease.
No, granulomatous breast is at 65 years of age is very, very uncommon, rather unheard of. Granulomatous mastitis is usually in 5 years post-pregnancy. At this age, if you have, say, a sort of chronic breast abscess-like feature, what is the factor?
No, tubercular breast disease, or no, that is granulomatous.
No, the commonest reason is duct ectasia leading to periductal mastitis. Okay, as age increases, there is more and more of ductal dilatation. There is duct ectasia, periductal mastitis, which can give rise to breast abscess. Whereas lactational breast abscess in the young age, idiopathic granulomatous mastitis is in the young age. Tuberculosis, of course, can occur in any age, but elderly patients having tuberculosis is not so common. So classically, it would be a breast cyst with a traumatic fat necrosis, and third is a chronic breast abscess with, but in that case, there will usually be overlying skin involvement.
Yes.
As in younger age, the whole differential pattern will change to, as you said, fibroadenoma, phyllodes, adenosis, IgM, GM, traumatic fat necrosis, chronic breast abscess, the whole list. Clear?
Yes, sir.
Again, when you are presenting in front of an examiner, your differential will change. If you have a lump only, then there is a one set of differential. If you have a lump with overlying skin involvement, that's another set of differentials that you are going to talk on. Clear?
Okay, sir.
So how would you investigate this lady?
So she is a postmenopausal lady. So initially we'll go for an imaging investigation in the form of bilateral mammogram. And
Utter the term. I'll complete the triple assessment. That is the usual
yes,
answer
sir.
examiner expect. I'll
Yes, sir.
complete the triple assessment. I have already taken history examination. I'll go for imaging.
Okay, sir.
Now, Anuradha, I give you a small tips. During the exam, do not unnecessarily make these statements like, as the lady is postmenopausal, I am going to go for a radiological evaluation mammogram. So you need not tell that. You tell, as sir has told, triple assessment, and triple assessment comprises of clinical breast examination, which I have done. I would follow it up with a radiology, which includes this plus this. So what are the radiological imagings you will do?
Sir, more than 35 years of age, we will go for bilateral mammogram. And if it is unavailable, then we can go for high resolution ultrasound of bilateral breast and axilla.
But if you are doing a mammogram, will you add an ultrasound, or you would not add
Yes, sir.
an ultrasound?
We will add an ultrasound to look for axillary lymphadenopathy.
No, you are going to, you always, it is when a radiology performs a mammogram, she or he will always add an ultrasound to it. It's part and parcel. You cannot do a mammogram only. An ultrasound becomes part and parcel of it. Even if you do not write, the radiologist will routinely get an ultrasound as a supplement to a mammogram to give a report. Clear?
Okay, sir.
What are the features in mammogram and what are the features in ultrasound you are looking at to state that this is a malignant lesion?
So heterogeneous hypoechoic lesion, irregular margin, taller than wider, and presence of punctate calcifications, microcalcifications.
Hold on. What do you mean by punctate calcification? What is the classical terminology for calcification in breast cancer?
Microcalcifications.
What, add more adjectives to this word microcalcification? It is called clustered pleomorphic microcalcification. Cluster means in a 1 square centimeter more than 5 dots is clustering. Pleomorphic means all the calcifications are different from another, and then microcalcification. Clear?
Okay,
So
sir.
clustered pleomorphic microcalcification. Okay.
Yes, sir.
Then what is the role of ultrasound? Apart from the diagnostic component of what you have done in mammogram, what advantage will ultrasound give you?
It gives a BIRAD score, and also presence of any axillary lymphadenopathy.
BIRAD is given by everything, but axillary
Yes,
lymphadenopathy. What character of in ultrasound would state that this is a metastatic axillary node?
it will be a enlarged axillary lymph node with a loss of hilum, and
Shape.
uh, the bean shape of the lymph node will be lost. It will be more of a round to oval shaped lymph
Yes.
node.
Okay.
Outline.
And the outline would be initially there will be increased prominence of the outline, and when there is adhesion of the when
Hello.
there is the subcapsular hello sir the subcapsular halo will be lost in case of due to presence of malignant cells. There will
Your
be
terminology,
increased blurring of the
Anuradha,
margins of the lymph nodes.
terminology, Anuradha, are wrong. There is nothing called subcapsular halo. Okay, halo is very lesional halo.
Yes.
Now you have need to understand that if there is a lymph node, the lymphatics come through the cortex, then goes through the whole of the lymph node and then comes out through the hilum. That is how the lymphatics flow. So if the earlier thing goes into the cortex, what it does is subcortical thickening takes place. There is a subcortical space where the metastasis takes place. So the earliest sign is subcortical thickening or eccentric thickening. Second phase is it goes into the center, leads to loss of fatty hilum. The third phase is change from a bean shaped to an oval shape. So this is sequentially. And fourth is you can actually demonstrate perinodal dissemination of the disease. Clear?
And Doppler for vascularity.
Yes, sir.
You have done the second. What is the third investigation you are going to do?
So we have to do a tissue diagnosis. We'll go for core needle biopsy.
What?
Okay.
Unguided or guided?
Sir, if it is a large lump, usually more than 2 centimeters, then we can go for unguided core needle biopsy. If it is a variegated or a smaller lump, then we
But I
have
think in the
to.
exam, it is better to say I'll do ultrasound guided core biopsy. That is the standard of care. What, Dr. Shweta?
Sir, actually, we recently, 6 months back, created the ICMR guideline. All of you can actually go and visit the ICMR guideline. And we have a big debate on that, to be very frank. Dr. Anurag Srivastava was in favor of doing all patients ultrasound guided. And there was Dr. Sudeep Gupta from Tata Memorial. He wanted all to be a blind core. And finally, the ICMR guideline states that it can be a blind core. But for exam, I think the best would be a middle path. If you think it's a solid lesion in ultrasound, then and it's a palpable solid lesion, then all you can go for a blind core. But if it's an impalpable lesion or diffusely palpable lesion, then go for a guided core. If you find that it's a complex lesion with solid as well as cystic component, go for a blind core. Clear? So
Okay.
your ultrasound is going to tell you whether this patient would require a guided core or you can go for a direct core in a part of one-stop clinic. Clear? Are you going to go for an FNAC from the axillary node if there is a metastatic one?
Sir, your voice cracked, so I couldn't hear the question.
Will you do FNA from the axillary node?
Samindra,
Mute karo. Will you do a FNA from the axillary node?
Sir, if there are, if we are depending upon the management, usually we do not go for FNAC from the axillary node. If it is a early stage disease, then we go for breast conservation surgery and
You
with
have
sentinel
to
lymph
address
node
axilla
biopsy.
by some form of investigation. You cannot just do nothing with axilla. Here it
We
is
do.
clinically N0. Clinically N0.
Yes, sir. We do a sentinel lymph node biopsy, sir.
if you are finding that there is a metastatic node and the policy of your institution is axillary minimalism, then you can always confirm right at the beginning by an FNA to state that this is a metastatic node. Then you will not proceed to sentinel lymph node biopsy. Clear?
Okay.
However, if there are nodes which are N0 radiologically, you don't need an FNA.
Okay, sir.
Clear?
Yes, sir.
You're going to stage the disease.
Yes, sir.
Are you going to
Staging.
Yes, sir.
What staging? All.
Sir, if there are on T1 or T2 lesion with no axillary lymph node, T1 lesion with no axillary lymph node, then it is going to be a stage 1 disease. And if it is a T2
No, Anuradha.
Any investigation?
Question. In this
Will you work up?
are you going to go for a staging workup?
in early breast carcinoma, there is no need for a staging workup. For example, C3 thorax, abdomen, or a whole body bone scan would be required for a locally advanced breast carcinoma, not for an auxiliary for an early breast carcinoma.
But
Or
at least what minimum? What minimum you do?
Minimum, so we can go for a chest X-ray.
No,
No,
you don't do a liver function test.
And yes, sir, complete hemogram and liver function test.
no, not
And?
from you didn't get SARS liver function test alone.
And-
What is the rule of liver function test in staging?
Sir, I didn't get your question.
What is
liver
the
function test which may get altered. Suppose there is a underlying
ALP,
metastasis disease.
ALP, serum ALP might get altered, alkaline phosphatase.
okay? And if it is altered, what are your suggestions? What are the implications of altered alkaline phosphatase?
Hepatic metastasis
Or
or a bony metastasis.
exactly.
Yes, sir.
Yeah. So you have done everything. What is your treatment plan?
Sir, in this patient, my treatment plan would be preferably would be a breast conservation surgery, given the small tumor to breast ratio, followed by radiotherapy.
Only.
And along with breast conservation surgery, we can go for sentinel lymph node biopsy.
We can know. You have to say what is your plan. You can.
So breast conservation surgery with sentinel lymph node biopsy, and followed by radiotherapy. And
Radiotherapy is not a parcel of breast conservation therapy. You need not
Yes,
utter
sir.
it separately. But
Yes, sir.
what is your what factors your systemic treatment planning will actually focus
Yes,
on?
sir. Sir, in this patient, the immunohistochemistry came out to be ERPR positive and HER2 neu negative, and low Ki67. So hormonal treatment can be given as a adjuvant therapy following surgery.
Will you give any systemic chemotherapy to this patient?
3 centimeter, 3.5 centimeter lump. What else should be taken into consideration to decide about chemotherapy? Anything else?
Now, I give you a complete picture in front of you. This is a 2.8 cross 3.1 centimeter moderately differentiated infiltrating ductal cancer, margins free. You did a sentinel lymph node, 0 out of 4 came out to be metastatic. It's ER positive, PR positive, HER2 negative, Ki67 20%, with the age of the patient being 65 years. What is your choice of treatment?
So following
You have done a
some
breast conservation surgery. You have already done a breast. What factors would decide systemic chemotherapy?
sir, if there are presence of axillary nodes, and
What about the tumor characteristics?
if the tumor is more than 4.
Have you read the factors for deciding chemotherapy in node negative early breast cancer? You know them or you don't know?
Sir, I don't know, sir.
Hmm?
I don't know, sir.
Any costly investigation? Any costly investigation?
PET CT scan.
PET CT. How do you want to help?
PET CT is
Early breast cancer, node negative. How PETs can you help?
Have you heard of some genetic
Yes, sir. Oncotype and mama print.
anything else? Oncotype and Namaprint is not usually used in India. What are the usual thing that is used in India? What we commonly use is called can assist breast. Okay. These are all genomic profiling techniques.
That lady came to oncology summit, Manjari Baske.
Oh yeah, she has sold off her company now.
Yeah.
Yes. So can assist breast gives a score. If the score is more than 15.1, then chemotherapy is mandated. If the score is less than 15.1, then chemotherapy is not required. You can also look at the NPI. Now, suppose it's a 3.2 centimeter, it means it, and with a grade 2 node negative, that would come around 3.66 NPI. A 3.66 NPI will do good only with adjuvant hormone therapy. Clear? The NPI is calculated in tumor into 0.2 plus grade plus nodal status. So if compositely it is less than 3.4, no systemic therapy or hormone therapy only for high risk patient. 3 to 4.4 would do only with hormone. More than 4.4 will require systemic chemotherapy. Now you can calculate the NPI and advise. You can do a genomic profiling and advise. You can do a general risk assessment also and advise. Clear?
Yes, sir.
For best conserving, will you discuss with the patient or you take a decision yourself?
We have to discuss with the patient.
What you discuss?
Offer them both the choices. We have to, for in favor of breast conservation surgery, the points are that it will not be associated with removal of the whole of the breast, and there will be some cosmetic benefit. And but in the against it would be that the patient might have to follow up regularly for radiation therapy and should not be lost to follow up after surgery. And
Any risk for local recurrence you need to explain to the patient?
yes, sir. Only
But that should be more to the positive side. If you emphasize more on local recurrence, then patient may not agree. Okay, so it should be balanced.
Sir, the recent evidence that has come out, there are 3 major trials which came out in between 2020 and 2021, which suggest that breast conservation therapy is superior to mastectomy. This is because of the fact that in all patients of nobody knows why, but because of the fact that all breast conservation therapies you are giving radiation. Possibly radiation is the factor which is responsible for higher better outcome compared to mastectomy. 2 to 3 years back, it was a sort of non-inferiority trial. That is, breast conservation surgery was not inferior to mastectomy with 1% extra local recurrence rate. Now it is said that the local recurrence rate is same and the overall survival is better with breast conservation surgery. Sir, will I take a leave?
Yes. Thank you. Thank you very much.
You can continue the class for some time.
Yes.
I have to go to the hospital.
No, I will conclude. I have to go to the.
Thank you, Anuradha.
thank you, sir. Thank you, sir.
Thank you, Dr. Shekhar. Thank you.
Yes, sir.
Anuradha presented well.
Thank you, sir.
Thank you.
তুমি আগে পিঙ্কির ব্যাপারে ওগুলো সব গোছাও, কি চাবি টাবি দেবে, কি কাগজপত্র কোথায়, কি
কাগজে গাড়িতে সব এটা দিলাম তোমাকে, তো এটা প্লাস গাড়িতে বাকি বলে দিচ্ছি সবদিকে সব।
এখন কি সফিকার আমি যাব, তুমি বড় গাড়ি নিয়ে চলে আসবে?
না কেন, তুমি ছোট গাড়িতে আমি
আমার
যাবো।
এখন রেডি হয়নি, আমার দেরি হবে, এখন
কতক্ষণ দেরি হবে?
15 মিনিট লাগবে। বলছি কি এইটা সফিক এখন এটা আমি দিব।
আচ্ছা চলো সব বলে দিচ্ছি, চলো রেডি হও।
Thank you.